Nose for Neurosurgeons. A very interesting topic. I am Dr. Narendrakumar, consultant ENT surgeon from Chennai. Google Maps. It's an easy way to reach anywhere without anyone's help. Same principle is used in endoscopic sinus and skull base surgeries with the help of the navigation system. But the truth behind is, trusting the navigation alone can lead to a complication. So to avoid this, we have to know the good anatomical knowledge than proceed for the surgery. Neurosurgeon usually prefer axial view, but a ENT surgeon always he will be oriented with a coronal view because of the surgical approaches. In this talk, the topic will be very basic on nose anatomy, what a neurosurgeon must know. First picture shows the sagittal view of the nasal septum, where we see the septal cartilage, perpendicular plate of ethmoid, and vomer bone, nasal crest of maxillary and palatine bones. Second picture shows the lateral nasal wall anatomy, where the superior and middle turbinate are in the green color, the inferior turbinate in the orange color. These three turbinates directs posteriorly and relate to the clivus, where it divides the clivus into superior, middle and inferior parts. Coming to the paranasal sinuses, green indicates the frontal, violet ethmoids group, blue maxillary sinus and red the sphenoid sinus. Arterial supply, antero-superior part is by anterior and posterior ethmoidal arteries, antero-inferior by superior labial branch of facial artery. The posterior-superior part is supplied by the Sphenopalatine Artery, which is a main artery. Posterior-inferior part of the branches are by greater palatine arteries. Regarding the nerve supply, antero-superior quadrant is supplied by anterior ethmoidal nerve, branch of ophthalmic nerve, and antero-inferior quadrant is supplied by anterior superior alveolar nerve, which is a branch of infraorbital continuation of maxillary nerve. Posterior superior quadrant is supplied by lateral posterior superior nasal nerves, which is a branch from the pterygopalatine ganglion. Posterior inferior quadrant is supplied by anterior palatine branch from the pterygopalatine ganglion. Of course, olfactory nerves are distributed in the upper part of the lateral wall, just below the cribriform plate. Any transnasal skull base surgery when performed, make a note that these functions of the nose has to be preserved. So coming to the most important core topic of this talk is the endoscopic anatomy of the nose. This is the right side of the nasal cavity. When we introduce the endoscope, the first structure to be seen is the inferior turbinate. Lateral towards is inferior meatus, where the nasolacrimal duct drains. Medial towards is nasal septum. When we introduce the endoscope little posteriorly, you will see the posterior end of the inferior turbinate. This is a choana, where the eustachian tube opens. You will see the glimpse of the middle turbinate. This is the nasal septum posterior part, and this is a sphenoethmoidal recess. So a little wider view shows the inferior turbinate, middle turbinate, the choana, the floor of the nasal cavity, and this is a nasal septum, where we used to harvest the Hadad flap from this area. When we advance the endoscope in between the middle turbinate and the nasal septum, where the choana here, the sphenoethmoidal recess, if you trace it little above, you will see the sphenoid ostium, which is present medial to the superior turbinate. So identifying the sphenoid ostium is very easy. From the choana, approximately 1.5 centimeters above, along the sphenoethmoidal recess, you will find out the sphenoid ostium. This completes nasal stage. Sphenopalatine artery, the terminal branch of the internal maxillary artery, which in turn a branch of external carotid artery, enters the nasal cavity through the sphenopalatine foramen. And in the nasal cavity, it ramifies into two branches. One medial, the nasopalatine artery, passing above the choana, vascularizing the nasal septum. The other branch, posterior nasal artery, joins the lateral nasal wall to vascularize the turbinate. This artery forms a pedicle vascularized flap, Hadad flap. So points to be noted is, when you widening the sphenoid sinus, inferiorly the mucosa has to be elevated first, then using the kerosene punch, the bone is removed by preserving this artery. Because these flaps are very useful for the reconstruction of the endoscopic skull base defects. Next is the sphenoid stage. This is a sphenoid sinus ostium, which is widened. For orientation, this is a sphenoethmoidal recess, so choana, the nasal septum. When we do a posterior septectomy, we'll get a view of owl's eye appearance, where you see both the side of the sphenoid sinus ostium visualized like an eye. This is a rostrum of sphenoid, which can be removed using diamond drill or mallet and hooch. Chiseling out, you'll get a picture of both the side of the sphenoid sinus. This is the sinus septation, which can be one or many, has to be drilled out to get a picture like this. Posterior wall of the sphenoid sinus has a good exposure like this. The clivus Sellar, tuberculum, and superior tubus is a planum sphenoidale. These are the midline structures. Lateral to it is lateral optico-carotid rhesus. You will see the optic nerve impressions. This is a carotid paraclival, cavernous carotid, and the paraclinoid part of the carotid. Just repeating the same in the Sellar stage: paraclival carotid, parasellar, median optico-carotid rhesus, lateral optico-carotid rhesus, optic nerve, planum sphenoidale, and the sellar. Landmarks for identifying sellar floor is clivus below, planum sphenoidale above, carotid protuberance, optic nerve prominence, and optocarotid rhesus laterally. After exposure of the sellar bone, you will observe the sellar dura part. So making incision over the dura, you will enter into the intracranial structures. Dura over the sellar floor, tuberculum, sella, and planum sphenoidale is opened, seeing the pituitary gland here. Also it can gain to the main suprasellar neurovascular structures. Moving to the carotids, this is the lacerum part of internal carotid artery, the paraclival, as I said, this is a cavernous part, and the paraclinal carotids. I restrict my talk with only the nose anatomy, that too very basics what a neurosurgeon has to know, and I will not talk about any intracranial structures. These will be dealt in a separate talk. According to the Professor Daniel Simon, paranasal sinus is nothing but like a house where it contains many rooms. So compare this house as a paranasal sinuses, where this is a nasal septum and this is a left side maxillary sinus, anterior ethmoids, so posterior ethmoids, and sphenoid sinus. If you want to enter into each room, you have to open the door. So this is an uncinate first door. If you open it, you will enter into the maxillary sinus. The second door, the bulla, if you open, you will enter into the anterior ethmoids. Third door, basal lamella of the middle turbinate, you can enter into the posterior ethmoids. And the fourth door is nothing but basal lamella of the superior turbinate. If you open it, you will enter into the sphenoid sinus. This is well explained by Professor Stamperger as a lamella principle. So the first lamella is uncinate, the second is bulla, the third is basal lamella of middle turbinate, and the fourth is basal lamella of superior turbinate. You can see first door, second one, third door, and the fourth door. This is a sagittal view. Comparing the same with the axial view, the first is uncinate, second is bulla, third is middle turbinate, and fourth is superior turbinate. Here the endoscopic anatomy, the inferior turbinate, you are seeing the middle turbinate above. If you push the middle turbinate medially, you will see the first door, that's uncinate bone. If you open the uncinate, you will enter into the maxillary sinus. The second door is the bulla. This is the bulla. If you open it, I told that we will enter into the anterior ethmoids. You are seeing this basal lamella of the middle turbinate. Only after removing the anterior ethmoids, we will enter into the posterior ethmoids as well. So basal lamella of the middle turbinate. If you push the middle turbinate laterally, you will see the superior turbinate, the fourth door. Just I am pushing the superior turbinate laterally. You can also cut the lower part of the superior turbinate to visualize the sphenoid sinus ostium. So this is a choana over here. The sphenoid ethmoidal rhesus, above it is sphenoid ostium. Some of the precautions you have to note, like deviated nasal septum. You have to correct the septum before proceeding to the skull base work. Removing the sphenoid septa, make cautious, it can attach into the optic nerve or the carotid. So it has to be precisely removed. Next one is a sphenoid sinus pneumatisation. It can be sellar, presellar, or concal. Of course, sellar is most common and easy to operate. University of Pittsburgh team, they fantastically classified the endoscopic endonasal approaches to the ventral skull base into different types. Number 1, transfrontal. Number 2, transcribriform. Number 3, transplanum. And 4 is transsellar. 5 is transclival. And 6 is transodontoid process. Pictures courtesy to Aldo Stam book. You will see some examples too. This is a nasal dermoid cyst, planning to remove by transfrontal approach. This is a case of large olfactory groove schwannoma, planning to remove by transcribriform approach. Case of a large craniopharyngioma, planning to remove by transplanum approach, and combined with transsellar too. This is a case of pituitary macroadenoma, planning to remove by endoscopic transsellar approach. This is a clival chordoma with intracranial extension, where we can approach via transclival. Next is a brainstem compression secondary to rheumatoid degeneration, where the decompression of the odontoid process is planned by transodontoid approach. All this comes under sagittal plane. The next is anterior coronal plane. The first one is a supraorbital approach, planning to remove the fibroosseous tumor of the left orbit. Next is the transorbital approach, planning to remove the tumor in the left orbit which causing optic nerve compression. The next is the middle coronal plane, where it includes transpterygoid approach. Here the lesion is immediately lateral to the pterygopalatine fossa. Next is a Petrus apex approach. Here the lesion is cholesterol granuloma, which is proven already. Third picture shows the lesion in the Meckel's cave, superior and lateral to the right internal carotid artery, which can be approached via endonasal suprapetrous approach. Middle coronal plane includes transcavernous approach too. Next, in posterior coronal view, it includes infrapetrous approach, parapharyngeal space approach. The picture shows an extensive cardomer removed by transcondylar approach. We want to add a small point about prelacrimal approach. This is a maxillary sinus axial view. This is a nasolacrimal duct. The red color shows a frontal process of maxilla. We want to approach to the posterior wall of the maxillary sinus. Most of the time the nasolacrimal duct is sacrificed. So if we remove the frontal process of maxilla, we can enter into the maxillary sinus posterior into the infratemporal fossa or pterygopalatine fossa without injuring the nasolacrimal duct. Thereby we can preserve the nasolacrimal duct. This is prelacrimal approach. If you assume the orbit as a clock, we can do the endoscopic endonasal approach from 1 to 6 o'clock. Approach the lesion in the orbit. Reconstruction of the skull base defect is the most important part in the surgery, which is done by the versatile flap or nasoseptal flap, which is called as hard flap. Here number 1 shows the origin of the nasal septal flap area. Number 2, of the flap to repair the anterior ethmoid roof and cribriform plate. Number 3 is a position of the flap to repair the sellar and parasellar region. Number 4 is a position of the flap to repair the region of the clivus. Flap is based on Sphenopalatine Artery. This is a case of pituitary macroedema. After the tumor excision, active CSF leak is sealed with Haddad flap repositioning. Professor Daniel Simon described about the bimanual technique where the ENT surgeon holds the endoscope giving the view, where the neurosurgeon operates with his both hands, suction and the instrument, so he can get a better visualizing the surgical field than using the microscope to work as a team. This is a aerial view of the OR showing the 2 surgeons, nursing assistant and the anesthetist. The last few slides to show about the comparison of microscope and endoscope with my small assumption of some ideas here. This is a case of pituitary macroadenoma. Compare the lesion with the Taj Mahal in the aerial view. So the gate of the Taj Mahal is just a nose with this binostril. So we can approach it endoscopically now. The same view, you can see the gate, the nose, the lesion in the cella of Taj Mahal. The initial skull base surgeries, when it is used, this is a view, you will get the lesion. Look at the view of the Taj Mahal or the lesion when you use a microscope or the endoscope. Of course, the endoscopic gives a very panoramic view. If you advance the endoscope, you will see the cella picture like this, very close. By using the angled endoscope, this gives a fantastic view of the cella, suprasellar areas or retroclival areas. These are some of the benefits of using endoscope in skull base surgery. Bad guys don't deserve a nose. Our patients are always good guys. We have to preserve their nose. Also its functions. We should have a good anatomical knowledge, thereby avoiding the complications in endoscopic skull base surgeries. Successful skull base surgeries without complication can be achieved only by the team practice. Thank you one and all for watching this video. Thank you so much.